introduce Dr. Sharma. Dr. Sharma is the Donald O. Castell Endowed Chair in Gastroenterology at the Medical University of South Carolina, with a clinical and translational focus in neurogastroenterology and motility, particularly diabetic gastroparesis and Parkinson's disease. He obtained his medical degree at Virginia Commonwealth University, completed internal medicine residency at Temple University Hospitals, and GI fellowship at Penn State Hershey Medical Center. Dr. Sharma's research focus is understanding the pathophysiology of gut-brain axis in various conditions and developing innovative, non-invasive, and promising neuromodulation therapies through his insights, outstanding mentorship and collaborations, and his engineering background. He currently serves as a principal investigator of an NIH-funded multi-center randomized sham-controlled study investigating thoracic neuromodulation for diabetic gastroparesis, and one of the multiple PIs of one of the 5 centers in the NIDDK-supported gut-brain Parkinson's disease consortium. Welcome, Dr. Sharma. We're talking about you.
Turn around behind my back, seeing who you're talking about. All right, well, hopefully I can live up to that billing. Thank you, Nancy, for that introduction. And Paige, thank you for sharing. That is not an uncommon story, unfortunately, with how many people are suffering with the condition that you have. So hopefully this presentation gives you some insight. So here are my disclosures. The NIH grants that you mentioned, diabetic gastroparesis, will hopefully gives me a little bit of insight as seeing these patients for a long time. Relatively new to hypermobile EDS, but it's been about a year now I've seen them. Parkinson's disease is the prototypical gut-to-brain disorder, and just some quick facts about Parkinson's disease. Parkinson's disease GI symptoms start almost a decade before the onset of tremor and the movement parts of it. Parkinson's disease, the Lewy bodies, the changes in the nerves, are found in the enteric nervous system, the nervous system of the gut, 8 years before they're found in the midbrain and the brain. And then for Parkinson's disease, there are studies that show that track, it moves up from the gut to the brain in a mad cow-like fashion. Much slower than mad cow disease, but still moves up the gut-brain pathways, if you will. There's changes in the microbiome, gut leakiness, all those things that ring true in a lot of different conditions in that. So that's a background that I come from. So today we're going to appreciate the GI symptoms and disorders that the Norris Lab and Dr. Maitland has brought to light, review the GI literature, which is very scant for hypermobile EDS, and then review key lessons learned by peers that I'm fortunate to be interacting with here at MUSC, which is a very unique environment for this condition, and then preview some novel findings and features from my clinical practice. So this is a paper that I had a chance of participating in with the Norris Lab, and it just shows how dire the condition is. And I'm so fortunate to be able to try and make an impact on this disease. Average diagnostic delay, 22 years for patients, 22 years. That's unacceptable. Symptom onset at age 9, right? And then 85% chronic GI issues, okay? So gastroenterologists need to be involved. I know that Ann, when I heard one of Ann's talk, she was like, she put gastroenterologists in the villain corner because we would just do endoscopies, colonoscopy, endoscopy, colonoscopy, endoscopy, colonoscopy, and then had nothing else to offer. So it's because, you know, not only GI space, but a lot of spaces have a long runway of trying to understand this condition. And I think we're just scratching the surface. But if you look at all the GI conditions that have a relative risk, a higher proportion of patients to matched controls, you have an 8 times fold more risk of IBS. 75 might be a little bit too high for hiatal hernia, but hernias everywhere potentially. Appendicitis, celiac disease, functional dyspepsia, a lot of things that you go down. Feeding intolerance, 9 to 10 times more. And then also gastric dysmotility that people would describe 14 times more. So gastroparesis would fall in that category. So I'm a neurogastroenterologist. What does that mean? It means that we kind of intersect, or hope to intersect, I don't know if our neurology colleagues believe us, but between the gut and the brain, and look at the enteric nervous system, the second brain, the central nervous system, and then syntegrative centers in the vagus and the sympathetic pathways that connect the two. So the gut-brain axis. This is an international small group of people, so we are well connected through different societies in the United States, South America, Europe, Asia, and Australia. And we have an international meeting every 2 years. This year it's in Bogota, Colombia. And we have our own journal too. So as we get words out, then publications will start resonating with people. We have a Rome Foundation as well, which I just joined and became a part of. And before, we used to call these disorders that we didn't have a good physiologic explanation for functional GI disorders. Just like in a lot of conditions, they call things functional. We've started to move now to calling these disorders of gut-brain interaction. We still can't pinpoint that, like for hypertension, the blood pressure being high, like that level of accuracy, but there's so much evidence to suggest that there are problems in the gut that lead to pathology in the brain. So this whole is a shift to understanding the gut and brain are very well integrally connected. And there are so many different ways to evaluate this. And we're trying to standardize that in our multi-center Parkinson's grant. So these are all the disorders that Rome describes from the mouth to the anus, right? The ones that are of particular importance to hypermobile EDS are functional dyspepsia and irritable bowel syndrome. So functional dyspepsia, you have fullness after meals, postprandial fullness, getting full in a couple bites, early satiety, epigastric pain and burning for at least 3 months. That started at least 6 months ago. And then nothing on endoscopy, imaging that otherwise explains those symptoms. Irritable bowel syndrome is recurrent abdominal pain that occurs at least once a week, lasting for 3 months. And then it's related to either having a bowel movement or not having a bowel movement. So when we think of functional dyspepsia, we think stomach. And when we think of irritable bowel syndrome, we think small bowel, small intestine, which you have 10 to 15 feet of. So when I review the literature, there's 2 main big studies looking at hypermobile EDS. One was published in 2021 and one was published in 2024. What did they say? Well, they surveyed 600 patients with hypermobile EDS and matched them to 600 UK controls, and they gave them these questionnaires, quality of life, medical history, and healthcare utilization. And what did they find? Well, they found that people had significantly more bowel symptoms, so constipation or diarrhea, significantly more gastroduodenal symptoms, esophageal problems, and anorectal. So across the board, these patients had issues. If you looked at just abdominal pain, so the normal population had abdominal pain at least once a week or more frequent in about 14% of patients. And 14% of just the general population has at least abdominal pain once a week. In terms of EDS, 75% of patients have pain more frequently than once a week, and oftentimes multiple times a day and every day. And then in terms of the diagnoses that gastroenterologists give to patients, IBS and functional dyspepsia are way more prevalent in patients with hypermobile EDS and than the regular population. Much more GI visits, much more antacid use, much more analgesic use, neuromodulator, which are in the GI space, low-dose antidepressants is what we're talking about as a neuromodulator to blunt the firing of neurons due to distress from the gut, and then laxative use as well. So just taking the next iteration by the same group, then they surveyed 1,000 patients with hypermobile EDS and hypermobility spectrum disorder. They gained more information about POT, somatization, autonomic neuropathy, autonomic intolerance, psychological factors, and quality of life. And they used machine learning to say, hey, these are all our patients, put them in groups to see if you can differentiate them. And they found 3 clusters. What are the clusters? And this isn't them, the physicians or the researchers didn't group this. The computer told them to group the patients like this. So you either had hypermobile EDS and hypermobility spectrum disorders by themselves, no GI issues whatsoever. That plus irritable bowel syndrome as a diagnosis, and then that plus functional dyspepsia and irritable bowel syndrome together. Notice you don't see hypermobile EDS and hypermobility spectrum disorders with just functional dyspepsia. So it suggests that you need the combination of both to have to occur in a majority of patients. And look at the groups. There's almost 500 patients in that first cluster, right? 180 and then 337 in the bottom cluster with no GI issues. So this is what that looked like. And why are those clusters important? Because when you had cluster 0 with functional dyspepsia, stomach symptoms, and small bowel symptoms, you had the highest somatization scores. What does somatization mean? Somatization means that there's no identifiable cause for your symptoms, yet you're having very severe symptoms. So we call that somatization. So that was higher, especially for chest pain, dizziness, fainting spells, palpitations, shortness of breath. Compared to cluster 1, also they had the lowest health-related quality of life. Their quality of life was much more miserable than either of the other 2 clusters, and worse functional physical functioning and health overall. And then higher depression, as we heard, in that cluster, and significantly higher anxiety in that cluster. And then finally, more coexisting POTS in these patients as well. And that was also corresponding to more autonomic symptoms in general. So when they surveyed patients, they found specifically gastroparesis. This is just a survey. You can't diagnose gastroparesis on a survey, but a significantly higher report of gastroparesis in these patients. So functional dyspepsia and gastroparesis-related symptoms most differentiated all 3 clusters in these patients. Stomach specific, right? Stomach being involved or stomach-related symptoms seem to be identifying the most severe patients. So we have functional dyspepsia, and we talked about how you diagnose functional dyspepsia. That's really prevalent. That's 7% of the population, okay? Gastroparesis is much more rare. Gastroparesis is 0.3% of the population. So you need 6 cardinal symptoms for gastroparesis: nausea, vomiting, early satiety, being full in a couple bites, fullness after meals, pain, and bloating, to have those 6 symptoms along with a slow stomach on imaging to get the diagnosis, and no evidence of obstruction of the GI tract by endoscopy or imaging. You've probably had this test, Paige, right? So this test is the gastric emptying scintigraphy. It follows a 2-Gauss protocol. So it has 255 kilocalories. That is standardized. 2 grams of fat in egg beaters, so much jam, two pieces of toast, and so many cc's of water. So all that's calibrated. And if you have more than 10% of the meal at 4 hours, so they image you at 30 minutes, 60 minutes, 90 minutes, 2 hours, and 4 hours, more than 10% of that meal at 4 hours is diagnostic gastroparesis. So that's delayed gastric emptying. But you can also have rapid gastric emptying. So rapid gastric emptying means that in 30 minutes, you have 70% of that meal out of your stomach. That's rapid. I'm sorry?
I wish.
Right. Well, you don't, because even if you have rapid emptying or delayed emptying, symptoms are exactly the same. That's what it looks like. So, right. So that stuff, I mean, if you're nauseous already at baseline, getting a plate like that with eggs and toast is just disgusting, right? So you'll be more nauseous. So my patients often ask, do I have to effing repeat this meal or this test again? And I feel bad for them, but sometimes yes. Okay, so what do the images look like on this test? So the images you can see here, you can see that they take it in different positions, but at 240 minutes or 4 hours, that outline of the stomach, everything is gone. That's normal, right? And then you see most of it in the stomach. Now, what do you notice about these images? These are scintigraphic images, right? So they're trying to trace radio tracer. Dr. Norris knows this because he does this in animals all the time, right? But when you do this, you don't have good localization of anatomic structures. You're guessing where the stomach is. You're assuming the stomach's right there, but it may not be, right? So these are radiologists that saying, oh, the tracer looks like it's in the stomach there, and then if it moves down, then it's out of the stomach, okay? So not good localization of anatomy here. This is rapid gastric emptying. I see at 30 minutes, more than 70% is out of the stomach, that's what they say. And then this is delayed gastric emptying. You see at 4 hours, not a very good image, but at 4 hours down there at the bottom right, a lot of it's still in the stomach, okay? So that's what we look at, that's what radiologists look at, and that's how they make the diagnosis. Now this is a study done by the Gastroparesis Consortium. They followed gastroparesis patients for up to 10 years and patients with gastroparesis-like symptoms for up to 10 years. Now the symptoms between gastroparesis and functional dyspepsia are very, very similar, okay? So the blue shows the gastric emptying over 4 years. So they take the test and they repeat it 4 years later. So you can see here that on panel A, they go from delayed emptying to normal emptying rates of the stomach, and then red is their symptoms. They don't change one iota. 40% of people go from delayed emptying to normal emptying the stomach, and their symptoms don't change. 40% of people go from normal emptying rates of the stomach to delayed emptying rates of the stomach, and their symptoms still don't change. So there's a disconnect between rates of emptying of the stomach and symptoms. These are the symptoms, this is how you diagnose it. But this brings into question, do you really need a delayed stomach emptying? I mean, how much does that really help us? And so just to step back, the stomach is not a tube like most of the GI tract. The stomach has different portions that do different things. The top part of the stomach, when you eat something, actually relaxes and expands to accommodate your food. And in that expanded space, then acid and things that break down proteins start to work and help you start to digest. And then as it moves down to the bottom part of the stomach contracts in rhythmic fashion to really pulverize these particles of food to less than 3 millimeters to then get sieved by the sphincter muscle at the end of the stomach, the pylorus, to then allow food to get absorbed into the small bowel. So that's how it works. And then after you're done eating, you get these rhythmic contractions that sweep the residual particles, the fiber stuff, out of your stomach when you're fasting. And that's what we call the MMC. And there's an indication, there's a way to tell that. So for gastroparesis specifically, there is only one FDA-approved medicine. It's metoclopramide or Reglan. Unfortunately, it has an FDA black box warning that can cause Parkinson's disease, essentially. The tremor, dystonias, so you got to watch out for that. Who does it cause it more in? Elderly patients, female patients, diabetic patients, patients with kidney and liver disease. Otherwise, there's a gastric electrical stimulator that can be implanted by surgeons, and that is not approved for routine use, but compassionate use. Okay? Now, I love stimulation, I love neuromodulation, but if you put a wire on a nerve that doesn't move, fine. But even in gastroparesis patients, the stomach moves. So the lead can either migrate in, which I've seen happen, and then it has a little lead at the end and ball valves the pylorus, and it can cause intermittent gastric outlet obstruction, nausea, vomiting, that looks like gastroparesis, or it can come back out in the perineum and then cause a bunch of fibrosis in the perineum and scarring there, right? So not my favorite thing. If you look at, it's not because people haven't tried to come up with more treatments. 16 drugs are less effective than the sugar pill or placebo when studied in randomized trials for gastroparesis. All 16 of those drugs speed up the stomach, but don't improve the symptoms one iota. Another piece of evidence that shows that emptying rates of the stomach and symptoms are disconnected. So for my space, when I wrote my grant, and you have to write a grant, there's an unmet need. This is a huge unmet need. There's really nothing to help these patients. So other than that egg meal, what else can we give people? This is called the wireless motility capsule or smart pill. It was on the market and they got pulled a couple of years ago. It's a nice test because it's better than eating those nasty eggs. You eat a bar and then you swallow a pill and you wear a recorder, and the recorder has 3 sensors on it: acid sensor, temperature sensor, and pressure sensor. Based on those 3 parameters, you can get your stomach emptying. You can see the green line is the pH. When the pH falls into the acidic stomach, and then when it rises 3 units, it goes out of the stomach to the small bowel. You have gastric emptying time. When it falls by 2 units, you go from small bowel to colon, and when the temperature drops, it comes out of the body, that's your colon transit time. So you get that whole profile in one test: stomach emptying, small bowel transit, and colonic transit. Why is that important? So this is just next saying that wasn't available. It hasn't been available. Now we have 2, and I'll go over those 2. So it's important because here, almost 50% of patients, it's not just the stomach that's slow. The colon is also slow. So that's something that was not really apparent until we started doing these tests. We are now getting this capsule, which is the gas sensing capsule. So it uses those parameters as well as other parameters of oxygen, because they're stuff that has low oxygen environments in the gut and high oxygen environments in the gut, to help tell it. So now this should be available pretty soon in our clinical practice to help with patient characterization. When the Gastroparesis Consortium also followed patients for a long time, they tried to figure out what, if gastric emptying doesn't correlate to symptoms, what does? So in 60% of patients, they found that 60% of patients had moderate to very severe constipation that was being unaddressed. And it was only the severity of constipation that correlated the symptoms severity of gastroparesis. So we need to finish that loop and say, oh, if we effectively treat people's constipation, then their symptoms get better. Haven't done that yet. This is another new technology. It's called the EGG, electrogastrogram. So you put a pad which has 64 electrodes on it, and then AI determines which leads are the best, and it kind of is like the EKG of the stomach. So it tells us how the stomach is, the electrical activity in the stomach is synchronizing contractions of the stomach or not. So this one is just new. It's not adopted as much in clinical practice because we're still trying to figure out what the values of this mean. We have in our research space. So that's everything with measuring stomach function. What about this gut-brain axis? What about, does the gut and the brain talk very well together? Well, in gastroparesis patients with diabetes, this study, they put an electrode into the rectum and they delivered a little bit of electricity. And they found that compared to patients without diabetic gastroparesis, that the diabetic gastroparesis sensed that a lot later than patients without gastroparesis. So gastroparesis people had hyposensitivity of their gut. They're not getting the sensation of the gut that they usually get. And that correlated to shifts in brain activity that represented the gut, and potentially explains a neuropathy of the gut-brain axis that may be explaining symptoms. So how do you get at this? Well, since medicines have all failed, you can do stimulation. You can stimulate the vagus nerve, which was done here. So they stimulate the vagus nerve for multiple conditions, migraine, headaches, etc. It's taught to stimulate these pacemaker cells of the stomach called interstitial cells of Gall and generate slow waves. And then also it may activate anti-inflammatory pathways in the body as well to decrease inflammation. FDA approved for epilepsy and depression. You can get it implanted. There's also this device here where they've studied in non-diabetic gastroparesis, found 40% responders, but no change in emptying and no change in autonomic function. Problem with stimulating with electricity in the neck is that to get to a specific intensity that may make a difference, it may hurt. It may be discomfort. So they now have a vagus nerve stimulator that drives the auricular branch of the vagus nerve. So the branch to the ear of the vagus nerve, they actually put leads within the ear to try and stimulate the vagus nerve. And they have done that, and that targets the nausea centers of the brain. And they've done that for pediatric patients with functional abdominal pain, and they've shown that this is improving their symptoms of functional abdominal pain. So this is available for pediatric practice. In the fall, it just became available for adults, and we're trying to implement this into our practice as well. So another way to stimulate nerves is using magnets. Has anybody heard of TMS? Okay, this is the place for TMS. MUSC, right? I mean, this is where it was developed 25 years ago. So talk to the psychiatry is just one building over, and they have been doing this for so long, and they've found level A evidence for the treatment of depression. They zap the dorsal prefrontal cortex, the region of the brain responsible for mood, 3,000 times for 30 days in a row, and that improves treatment refractory depression. So in my prior institution, we tried this for fecal incontinence, and we found that we could improve fecal incontinence by stimulating the lumbosacral nerve roots around in the lower back. And then when I had all these gastroparesis patients that didn't respond to anything and I was desperate and I had this whole setup, I was like, hey, why don't we try and do the nerve pathways from the stomach to the brain? We moved the magnet up into the mid-back and targeted the thoracic spinal nerves, and we made a protocol. We did a proof of concept study in about 7 patients. The last 4 patients, we got our settings correct, and we found a dramatic decrease. Now, these gastroparesis symptoms, there's a lot of day-to-day variability in gastroparesis symptoms. There's about 80% variability in day-to-day symptoms. So if you do a 7-day average of symptoms, you get more of a global assessment. So this is a week-to-week-to-week tracking of symptoms. So when we had our parameters correct, we had a 75% decrease in symptoms in that first week of treatment. That went down to 98, 97% in weeks 2 and 3. And a lot of treatments, they target nausea, or they target fullness, or they target pain. You had a better than 60% improvement across the board in all the symptoms of gastroparesis. Who's this guy? He just left. Look at that, he's gone. I'm calling him out right now. So Dr. Norris is obviously a leader in the field of EDS. And I've had many conversations about GI issues in EDS. And one thing he's emphasized through his research is that this is not a collagen problem. EDS is not a collagen problem because the genetic defect is not in the collagen gene. It's in the immune gene involving complement, which is this paper done by his postdoc, Courtney. And we are affecting immune pathways, and collagen is being consumed faster than it's produced. Okay, so that is one of the pathophysiologies. There's multiple types, and Ann will tell you, and Dr. Maitland will tell you that there are so many types of EDS. They all involve the collagen gene. This one does not. But in my discussions with her, I know that picture is blown up, so maybe pixelated. There seems to be multiple immune dysfunctions and of varying degrees, right? So like we have 13 subtypes of EDS, I think we're going to get to a point where we have 13 types of hypermobile EDS. And that we're just scratching the surface as to find out what the pure pathophysiology and immune dysregulation is and trying to target that. Until we do that effectively, we're just spinning our wheels with symptoms, okay? So I hope that we soon get there where we're actually identifying the exact defects and finding treatments for each one of those. And once we do that, then hopefully people will start to get better from that standpoint. And then this is Dr. Patel in neurosurgery, and he would tell me a couple things in his conversations. We have all these tethered cord patients, and we do their operations. Everything mainly gets better, but their GI symptoms don't get better. And also, he was a very big impetus with a patient of his to get a stand-up MRI at MUSC to help diagnose occult tethered cord syndrome, which means that there are positional issues with symptoms. So, on that case, when I talk to patients with hypermobile EDS and gastroparesis or gastric symptoms, they tell me, Doc, my nausea, my pain, everything is worse when I stand up or sit down compared to lying down. So that is where this study comes into place that we started doing maybe 3 months ago. So the study is we do an oral contrasted study. We get x-rays in the lying position and in the standing position. And what do we see? We see visceraptosis, or more specifically enteroptosis and colaptosis. Anybody heard of ptosis of the eyelid? I have slight ptosis of my eyelid, so that's why I don't like close-up photos. But here you can see that this is lying down, but all the intestines are down. These are your hip bones right here. These are your hip bones. So if your intestines, which should be floating in the abdominal cavity, fall into your pelvis when you stand up, that's pretty miserable. That's not IBS. That's not just a disorder of gut-brain interaction. That's a structural disorder. But I wasn't the first person to identify this. There are gastroenterologists that talk about gravity intolerance all the time, that have described visceroptosis. And then this study done by Cedars-Sinai, they took 20 healthy matched controls and compared to 10 hypermobile EDS patients. 10 is not enough. And there's a lot of limitations to this study, but in effect they found that even the matched controls had descent of their small bowel as much as EDS patients. So maybe something, maybe not something, something we need to figure out. But what about the stomach? They didn't describe gastroptosis. Think about if your stomach, which is supposed to be up here below your diaphragm and your rib cage, falling all the way to your pelvis. How miserable is that? So here we have the stomach in the supine position or lying down, right below the diaphragm there, right under the lungs. And then when they stand up, boom, all the way into the pelvis. Okay? So remember how we talked about the top part of the stomach expanding and relaxing to allow you to accommodate food? Well, if you're sitting up or you're standing up and there's no way the top part of the stomach, which is being stretched and pulled down, is expanding at all, what do you think you're going to feel? Nausea, pain, vomiting, all those symptoms of gastroparesis. And then a second thought about this, we went over the stomach emptying test and the scintigraphy, right? And your radiotracer, you may get diagnosed with gastroparesis. I'm not saying you're not going to get diagnosed with delayed emptying, but a lot of severe patients, the radiotracer goes from here, boom, down into the pelvis, and they don't think it's in the stomach anymore because they have no idea of telling that's the stomach or small bowel, and they say rapid gastric emptying or normal gastric emptying, right? So we can't necessarily rely on that test because this situation isn't meant for that test. They don't anticipate the stomach not being where it should be. So just a couple thoughts about why this is a little bit more complex. Now, what do you do for this? I have no idea. I know what I know and I know what I don't know, and I don't know what to do for this yet. Do you do surgery? Well, we're going to write 2 PACE reports where people have had surgery for this and see how they're doing. They're not perfect. Maybe they're a little bit better. We'll see. Do you put in feeding tubes? Well, I've had patients with feeding tubes with this where the feeding tube is so pulled into the abdomen that so you usually have a GJ tube, and the jejunal tube, it goes into the small bowel and feeds, where the G tube vents, right? And if you vent enough and you have this problem, you could imagine the stomach already being distorted and contoured where things preferentially just come out the vent and don't go through into the small bowel and nutrition doesn't get absorbed. I don't know what to do about that either, but just observations, right? So some take-home points. I've started doing this for 3 months. We hopefully have about 20, 25 cases that we'll look at in detail, try to find patterns from a medical history standpoint, from an everything standpoint, and hopefully get more insight, because not everybody has this. This is obviously a severe case, right? But people have varying degrees of this, and it makes sense that if you have hypermobility and a collagen, a connective tissue secondary problem, not primary, secondary problem, why GI? Why GI? The reason it's GI is because the abdominal cavity has so much space to move. Your joints are usually supported in place, right? They may move out of place, right? But your abdominal cavity is this whole space, right? So implications about if you have a hysterectomy or you have GI surgery and there's more space created can be more problematic. So need to learn a lot more about this.
Question. So like the bladder, they do a sling procedure, they can't do any kind of a sling thing?
Yeah, so I mean, you can tack up bowel or the stomach if you have a big hiatal hernia, which is the stomach into the chest, the opposite of this, right? Then they tack the stomach on the bottom side of the diaphragm. The problem with hypermobile EDS is, and anybody really, is those can become points of torsion and twisting, right? So, I mean, in our hypermobile EDS patients, we're hyper-aggressive about constipation, because if you have a high stool burden and if you're thinking about a pendulum and one side twists, then it will be miserable. It will be miserable. So yeah, it's not black and white that operating is going to be, and what operation to do is going to be beneficial. Now, another thought about this, now that you're having me think instead of just speak, if the stomach and small bowel fall to this degree, when you stand up, what comes with it? Not vomiting. Yeah, that comes with it. Not just, but also passing out. Why? Because you've probably, if you have POTS, gone to a cardiologist as a 20-something-year-old female with EDS. They've done an echo. They've done a stress test. They've done every exercise, every test in cardiology. Everything's normal. Your heart is fine. You're young. Go enjoy your life. Get out of my office, right? But if your stomach and your small bowel are falling in your abdominal cavity, what's coming down with it? All the vessels associated with that GI tract. And if the vessels are coming down with the GI tract, that's 25% of your blood return to your heart. And if 25% of your blood return to your heart isn't coming back up with you when you stand up, your blood pressure is going to drop, your heart rate's going to rise, and you're going to have POTS, and you may pass out. That's not a heart problem, though, right? So a lot of things to think about. We don't have the answers, but we're actively thinking about it.
So it seems like everybody with POTS should have that test too.
Well, so if you go back to the study where they surveyed 1,000 patients and they had machine learning cluster patients, right? They found there was 3 clusters. There was hypermobile EDS and hyperspectrum mobility disorders without any GI symptoms, one with IBS, and then one with IBS and functional dyspepsia. So as soon as you start having functional dyspepsia, that cluster with all 3 had more POTS, more autonomic symptoms, right? So that might go with this right here. So.
Just your thoughts on, there's a lot of psychiatric overhaul, and when you hear the term functional anything,
Yeah.
and, partnership
Yep.
between the practitioner and the patient, who literally has had years of people either not acknowledging, not seeing, and what have you. How do you get around the language when you use a term like that?
So I will say that we talked about the gut-brain axis, and we mainly focused about gut-to-brain pathology. But there's also brain-to-gut pathology. So if you've been ill for 22 years to get a diagnosis, and you've suffered every day, that's traumatic. And that's traumatic to the level of PTSD from going to war or whatever. So studies have shown in IBS, I'm not talking about hypermobile EDS, that instead of neuromodulators, low-dose antidepressants, cognitive behavioral therapy is effective, much, much more than any medicine or intervention that we do. So I have a cognitive behavioral therapist with me to help, because if we are already sick from a GI standpoint or pain standpoint, and then we also add anxiety and catastrophizing I mean, this is a catastrophe. Stomach falling all the way to pelvis is a catastrophe. But if we also rev our stuff up, then we make things worse. It feeds each other. The symptoms get worse and worse and worse. So cognitive behavioral therapy is something that I offer my patients because we need strategies to try and deregulate or that side. So yes, that's been my approach. I mean, I'm open to other ideas. The gut-brain axis is also thought to influence depression and anxiety. 95% of the serotonin in our body comes from our colon. And then there's interchromaffin cells that produce all kinds of hormonal molecules and endocrine molecules. And they talk very closely to the afferent nerves, sensory afferent nerves from the gut to the, I like spinal nerves more, to spine and then up to the brain. So there's a lot of crosstalk. Maybe neuromodulation of that toward in the future would help. Okay, so take-home points. We talked about the significant GI burden. We talked about pathophysiology being multifactorial and actively being understood. We're still in process. Optimal management requiring multidisciplinary teams, right? Both basic, Dr. Norris kind of bounced, but basic and clinical scientists working closely together, just like we have here at MUSC. With that, I'll take any questions.
Thank